Hello, it's midday. I've been told to start, so I hope that people are watching for this incredibly important event that I'm really delighted to be hosting. I'm Elizabeth Day. I'm an author and podcaster, and I'd just like to thank Tommy's for asking me today. I am delighted to welcome you all to Tommy's Miscarriage Matters event. This is a unique opportunity to meet the wonderful team behind the groundbreaking Lancet Miscarriage series, which we hope will change miscarriage care forever. As some of you might know, this is a cause extremely close to my own heart. I have been through 3 miscarriages, and I know only too well the emotional devastation that it can cause and how one can often seem and feel overlooked by large parts of the medical establishment. I'm therefore incredibly grateful to the researchers I'm going to be speaking to today, and incredibly grateful to Tommy's, who at dark points in my life definitely made me feel less alone. I know that many of you are already Tommy's supporters, either through funding or through sharing their important work, and we're so pleased you've been able to join us. Just to let you know, the event is being recorded to create a highlights video, which we can share, but if any of you want to take screenshots to share on social media, you're very welcome to do so. And if you have any questions for our panelists, just pop them into the Q&A tab. That's the Q&A tab and not the chat tab. And also ignore the raised hand emoji. So just pop them into the Q&A tab and we'll get to them in the back half of this session. Thank you all for giving your support to something Tommy's has been working so tirelessly on. It started when they opened their National Centre for Miscarriage Research in 2016 to challenge the idea that miscarriage was an inevitable part of a pregnancy journey and entirely unpreventable. The result is the world's first Lancet series looking at miscarriage, bringing the issue into the public eye to call for changes to guidelines which are frankly outdated and unfair. I'd like now to introduce you to the team. Centre Director, Professor Arri Coomarasamy, Professor Siobhan Quenby, and Professor Phil Bennett. Sadly, Professor Tom Bourne can't join us today, but I'm delighted to welcome you 3. Thank you so much for being here. Arri, could you start by telling us a little more about the research findings, please?
Thank you, Elizabeth. Sure. So our aim with this series was very much to dispel the many misunderstandings that are out there, many misconceptions that are out there on the subject of miscarriage. And we wanted to do this with evidence, with research evidence. So what we did was to go and gather the evidence out there and meticulously analyze it so that we could be confident with the findings. And the findings are very clear, Elizabeth. What we found and what really stood out were, I guess, these 3 areas. The first was that miscarriage is an event that goes well beyond the physical event. We know that in the past, miscarriage has been kind of treated in isolation, and we thought the key issue with miscarriage is to kind of work out what's the risk of recurrence, and that's pretty much where care stopped. But now we know that if a woman has a miscarriage, then she has great risk of other complications in future pregnancies. So for example, the risk of preterm birth is increased, the risk of stillbirth is increased, placental problems like abruption, these are all increased. Not just that, we also know that miscarriage has profound mental health consequences for many couples. So as many as 1 in 5 women could have post-traumatic stress disorder after, say, 9 months after the event. So the first clear message that emerged was that miscarriage isn't an isolated physical event. The implications go well beyond the miscarriage event. The second key message that came out in our series was what you rightly mentioned. There is this idea out there that miscarriage is an inevitable event. It's the way that nature deals with a pregnancy that is not normal. Whilst that is true for some pregnancies where the baby might have a chromosomal or genetic problem, we now know that there are many miscarriages which are loss of a pregnancy that is normal. And such pregnancies could potentially, they don't need to end up as a miscarriage. So there are things that can be done. There are things that can be done by women and couples themselves. So for example, achieving the appropriate body weight, cutting down or stopping smoking, not taking alcohol, all of these can reduce the risk of miscarriage. But the healthcare providers can also help in terms of reducing the risk of miscarriage. So for example, we know that women who've had a previous miscarriage and who are now bleeding in the current pregnancy, if they were to take the hormone treatment, progesterone, then their risk of miscarriage could be reduced. So, it's not a hopeless situation. There are things that can be done to reduce the risk of miscarriage. I guess the third key finding was to dispel this, outdated, unfair practice, which is that a woman had to have 3 miscarriages before she would be offered any specialist care. Now, we know that even after 1 miscarriage, the risk of the miscarriage, a future miscarriage recurring, the risk of preterm birth, psychological consequences, all of these go up even after 1 miscarriage. So what we are now saying is that every woman after every miscarriage needs to get appropriate care. It doesn't mean that a couple need to attend a specialist clinic, but what it does mean is that we need to identify risk factors and address issues that may be important to reduce the risk of miscarriage. So I think the series is very much about reshaping practice, and really it's a clarion call to change the way that we look at miscarriage.
Thank you, Arri, so much. I mean, just hearing you talk like that, it's a miracle that anyone gets pregnant and has babies, isn't it? It's just sort of extraordinary, mind-bending feat. Siobhan and Phil, I'd love to hear a little more from both of you about your own areas of interest and how they fed into the series. So Siobhan, can I start with you?
So for many years, I've run a recurrent miscarriage clinic, and the sort of frequent stories I hear from people are that they feel rejected by the health service because after 2 miscarriages, they were told they couldn't be referred to my clinic until they'd had a 3rd one. And so I think the big news of moving from that system to this graded care model will be really helpful. So the new model is every miscarriage matters. So after each miscarriage, there is some care that's appropriate to the patient's history. So after 1 miscarriage, there's a lifestyle advice. After 2 miscarriages, some basic blood tests. And then after 3 miscarriages, more complicated blood tests. So I think this is going to make a real benefit to the patients. The other thing that I think that Arri hasn't mentioned yet, there'll be a big benefit to the patients, is how you miscarry. So when you have a miscarriage, you get a choice between what we call conservative management or just miscarrying alone on your own, having tablets to speed the process up, or having an operation. And I have a lot of patients explain to me how bleeding for a long time after the medical management has caused them a lot of distress and worsened this post-traumatic stress, anxiety and depression. And the analysis of the best way to have your miscarriage care has shown that surgery actually has a better completion rate. And I think this will change the guidelines. I think it will change the way we talk to people and reduce some of the stress, anxiety and depression that I deal with on a regular basis.
Siobhan, thank you so much for that. I said earlier, I've had 3 miscarriages, and actually each one was dealt with in a different way. So I've had the full gamut of experience. And I totally agree with you that actually the surgical one was the best for me. The medical one where I took the tablets was by far the worst. And the natural one, I was really astounded by how much bleeding there was. So thank you for sharing that with us. Phil, can I come to you? What are your specific interests?
So let me say first of all that the Tommy's Miscarriage Centre is a collaboration between the 3 universities, Imperial, Birmingham and Warwick. And I think one of the reasons why it works so well is because each of us brings different interests. So Tom Bourne should have been here with me from Imperial. So Tom is very clinically orientated, good at ultrasound and looking after women who are at risk of miscarriage. I'm much more interested in the underlying science of what's happening. So Tom, for example, very early in the Miscarriage Centre time, published new diagnostic criteria for miscarriage based on ultrasound. Before that time, the criteria that we had been using had meant that a very small number of pregnancies that were actually viable and could have gone on to be successful pregnancies were being incorrectly defined as a miscarriage. And actually, we were, in a very small number of cases, terminating wanted pregnancies. Now, that has changed practice worldwide, has probably saved thousands and thousands of lives. And Arri's also mentioned, I think, the quite important work that Tom has been doing on the psychological impact of miscarriage. You might think that miscarriage would cause you to be depressed. That's, I think, what I thought before this research came out, but it's not that at all. It causes post-traumatic stress disorder. And I think recognizing that, and the fact that so many women, as Arri said, 1 in 5 women at nearly a year after a miscarriage are still experiencing those psychological problems, is something that we need to recognize, and we need to do something about it in terms of looking after people. My own interest is largely in the way in which the body interrelates with bacteria that live on and in our bodies. In the 20th century, we used to think of bacteria as bad, and if you've got a bacterium, you had an infection. But in the 21st century, we know that we all live in an important symbiotic relationship with bacteria that live all over us. We need those bacteria for life. And what we have found is that miscarriage, and particularly miscarriage where the pregnancy is chromosomally normal, links to an imbalance in the bacteria which are living in the genital tract. That's interesting because it also links to preterm birth and growth restriction. We're finding the same things with preterm birth and with placental abnormalities like growth restriction. So this may explain why miscarriage, and especially many miscarriages, is a risk factor for other adverse events down the line. And it might also explain some of the ethnic diversities in miscarriage, the increase in the risk in Black women. So we're looking, at the moment it's hard to diagnose these things. It's not easily done with a swab in a lab, but we're working towards things that can help us diagnose it at the bedside. And we're working towards treatments, which you would probably think of as a probiotic. We call them live biotherapeutics now, but these are not things that you just buy over the counter and swallow, because they don't work. These are specific bacteria that are the right ones to have in place. So I guess the question is, what can you do about it now? Because we at the present time don't have a direct intervention. Well, one thing is that spacing out pregnancies is good, because we know that after a pregnancy, particularly after the birth of a child at term, the bacteria don't go back to normal for perhaps up to a year or more afterwards. So having a decent space between your pregnancies help. Smoking changes the bacteria in your body. And we know that stopping smoking is a really good way to reduce the risk of miscarriage. And then some people have sort of douching habits where they clean themselves to try to, get rid of all the bacteria. But the trouble is that gets rid of the good guys as well as the bad guys. So we recommend not doing that. So that's the area that we're particularly focusing on at Imperial in my group.
That's fascinating. And when you talk about spacing out pregnancies, does that include pregnancies that have ended at 6-7 weeks, that have been early miscarriages?
Interestingly, the effect of a pregnancy on the bacteria actually depends to some extent on how long the pregnancy has gone on for. So it's less of an issue with miscarriages than it is with term births, actually. So the real, I think it's a good idea to space out your pregnancies anyway, for many other reasons, not least social and economic reasons. But it's particularly having a baby at term and then going on. There is an effect of miscarriage, but it doesn't last for so long. It only lasts for 2 or 3 months.
Okay, thank you. And I've got so many questions. One general one that I would like to pose is how difficult it is to research miscarriage, either because women, men, partners, couples don't necessarily want to talk about it and revisit it, or because, to put it brutally, there isn't that much material to examine a lot of the time. Arri, can I direct that to you?
Sure. So researching miscarriage has been difficult, Elizabeth, and I think there has been one profound reason, which was that it wasn't seen to be a problem where you could make a difference. You know, as I said earlier, miscarriage was thought to be one of those things. You know, it's nature's way of dealing with an abnormal pregnancy. So what can you do with that? That narrative has to change. We know that many miscarriages have a reason, and the reason might be to do with the lining of the womb. So that's the endometrium. We call it the endometrium, and Siobhan and Professor Jan Brosens, for example, look at the lining of the womb in detail, trying to understand, can we modify the lining in such a way that it supports a pregnancy? We know that there are hormonal reasons why miscarriages could occur. If there's a problem with, say, thyroid hormone level, or problem with the hormone progesterone, if there is diabetes, you know, all of these can contribute to the risk of miscarriage. We know that sticky blood disorders can contribute to the risk of miscarriage. And then there is, you know, newer target conditions, like if there is a problem with the microbiome, as Phil mentioned. So all of these are potentially amenable to research and therapies that could potentially reduce the risk of miscarriage in the future. But for a long time, we just thought, well, there is nothing that one could do. But you're right. I think the fact that, you know, women didn't talk very much about miscarriage meant that it wasn't always made into a priority. And I think, you know, same sort of sentiment has been prevalent even amongst healthcare providers and healthcare funders. And so investment in miscarriage has not been great. And of course, Tommy's, through you know, amazing investment that they made about 5 years ago to say, you know, you guys get together, start to understand what's going on here, start to find ways to make a real difference. And I think that investment has made a massive difference. And I think the financial investment is really important. Over and above that, the fact that the leading teams in the country, that is our team in Birmingham, the team in Warwick, and the team at Imperial, coming together and finding synergies and, you know, pooling our intellects and technologies and ways of looking at the problem through multiple angles has meant, you know, we've got a tremendous advantage to take matters forward. So yes, I think there have been problems in terms of researching to find solutions for miscarriage, but things are changing. And so we are now, the Tommy's Center for Miscarriage Research has been around for about 5 years, and we've done a lot in that time, but there's a lot more to be done in the coming years. And we are very focused on trying to find ways forward.
Thank you, Arri. We're so grateful for your work. Phil, if I can come to you on that notion, now outdated, that miscarriages are unpreventable. Is that true? Like, is there ever a miscarriage that happens for no reason?
I mean, I'm sure there's never a miscarriage that happens for no reason. And I think it's very important to get across the message that miscarriages are preventable. And that has been the problem in the past. I think, you know, when I first started to practice obstetrics and gynecology, when I had black hair rather than white hair, you know, we used to say to people, oh, it's just a miscarriage, don't worry, you know, just try again. And it's one of those things. And that's absolutely got to change. Arri said earlier, half of miscarriages are associated with chromosomally abnormal pregnancies. And you might think, well, yes, okay, that half, the reason for that miscarriage is the chromosome abnormality, and that pregnancy would ideally miscarry. But, you know, I think even there we can prevent that. Some of the work going on in Warwick at the moment with Jan Brosens, who, like me, is a person who's interested in the underlying science, has found that the lining of the womb has the ability to detect abnormal embryos. And one of the causes of miscarriage is that the lining of the womb doesn't identify the chromosomally abnormal embryos, so it allows them to implant. And that particularly happens in people who have recurrent miscarriage. So you get people that get pregnant very easily, but they miscarry because they're getting pregnant with chromosomally abnormal embryos. So even those, I think, as we begin to understand how that works, we can begin to solve that problem. And then for the rest, the other 50%, you know, Arri has mentioned, I think it's important that probably the single most important way to help prevent a miscarriage is to get the pregnancy off to a really good start at the beginning. So there are a range of different conditions like antiphospholipid syndrome, thyroid antibodies, maybe just having low thyroid levels, which are associated with a risk of miscarriage. There are some abnormalities of the womb which can be fixed, which associate with miscarriage. But even things like stopping smoking and being cardiovascularly fit and making sure that you're not either underweight or overweight, all of those things will help to get the pregnancy off to the best start, and therefore that miscarriage becomes preventable, if you like. And then Arri's already mentioned that there is now some evidence that particularly in people who miscarry over and over again, that in the pregnancy, treating them with progesterone might help. So of course, miscarriage is due probably to a wide range of different things. There's never going to be a single treatment which is going to cure all miscarriages, but it's probably the case that progesterone is curing one of those mechanisms, and it's a mechanism which is more common in people who tend to miscarry over and over again. So I think the story now is miscarriages are preventable, sorry, and there's a lot that women themselves can do and their partners, and a lot that we can do to help prevent them.
Okay, thank you. Just to remind everyone, I mean, I've got loads of questions, so I'm really happy to rabbit on until 1 p.m. But if you do have any questions, do put them into the Q&A tab and I'll be sure to ask them to this incredible panel. Siobhan, can I ask you about how these findings are changing the care that you offer parents in the Tommy Centre?
So there's several ways that it's changing care. So the first one is to talk a lot about general health. So to inform people what their body mass index is and what their ideal weight should be. To spend a lot of time on smoking, to talk about diet, nutrition, and general lifestyle. There was some slightly unexpected findings from the review, which was that, for example, shift working was associated with miscarriage, and that gives us an opportunity to discuss working patterns, stress, and stressful lifestyles. So that's made a huge difference. Then the progesterone has made a huge difference. So we now know that if you've had a previous miscarriage and you bleed, it's important to get progesterone. And so my unit spends a lot of time giving out progesterone. And we also know how very important it is to support people and identify people who clearly have some PTSD reactions to their miscarriage, and make sure that they have counselling and support from other people. The other thing we're doing is trials, trying to implement some of this into new causes and new treatments. So we're currently running a thing called the CERM trial, or chronic endometritis and recurrent miscarriage trial. So in that trial, you can actually have the lining of your womb tested to see if it's inflamed, and it's thought to be inflamed in a way that may be contributed to by the imbalance in the microbiome or the bacteria in your vagina that Professor Bennett has just explained to you. So you can have the lining of your womb tested in the trial. And if you are test positive, we're trying to find out whether or not an antibiotic called doxycycline reduces miscarriage and prevents miscarriage. And so it's a double-blind randomized controlled trial. So in the trial, you get some medication and you get another biopsy to see if the lining of your womb's got any better or not, and then see what happens to your pregnancy outcome. So the series has made a huge difference in terms of what we say to people every day, what preventative treatments we give, what support we give, and also to future trials to try and get even more interventions to prevent miscarriage in the future.
Great news. Can I ask specifically about what is termed a missed miscarriage? So a miscarriage where someone might see a heartbeat and then miscarries at a stage when mostly you feel like you're home and dry when you see a heartbeat. Did you do any specific research into that kind of miscarriage, and did you find anything out about that? I don't know who to direct that to.
So how to manage those came in paper 2, which Professor Arri Coomarasamy led. So do you want to talk about the network meta-analysis?
Sure. So yeah, with missed miscarriage, Elizabeth, sadly the heartbeat would have stopped, and the pregnancy is no longer continuing, but all the pregnancy tissues are still inside the womb. So the uterus hasn't started to expel the pregnancy tissue. So we call that a missed miscarriage. And incomplete miscarriage is where some of the tissues have come out already. So this is missed miscarriage. The issue with missed miscarriage is that the woman may not know that she's miscarried because the last scan might have shown everything was fine, fetal heart was there. And so it often comes as a huge shock, huge blow to discover that pregnancy had at some point stopped to grow. The research that we do is to stop all kinds of miscarriages, including missed miscarriages. And I think, a treatment such as progesterone, for example, could be useful to avoid that in the future. But in terms of somebody who's sadly suffered a miscarriage, then there are three options. One of them is to wait and see if the miscarriage would resolve naturally. The second is to use tablets to aid the process of expulsion of the pregnancy tissues. And the third is to have a small operation where a plastic catheter is put inside the womb to remove the tissues. What we now know is that with missed miscarriage, the operation is perhaps the most effective way of addressing the miscarriage. But for some women, the medical option would be the right one for them. They do not wish to go through operation. In that situation, then we've demonstrated that using two different tablets, two different kinds of medicines is actually better than what we do at the moment, which is to use only one type of medicine. So again, we've kind of given clarity about how you could make the tablet approach more effective. So yeah, that is very much addressed in the Lancet series of papers, and we are very much hoping that that would change practice in the clinics out there.
Thank you. There are some questions coming in from our audience, but before I get to them, Phil, I've just got a question for you, which is that we hear a lot, rightly so, about the impact miscarriage has on the people carrying the pregnancies, but what has your research shown about how partners are affected too?
Yes. Well, that's actually, again, not my research. That's Tom Bourne's research, but he did a very similar study to the study which we talked about previously, which showed that the relatively high rates of post-traumatic stress disorder in women following miscarriage. Well, unsurprisingly, because, a pregnancy is usually a planned thing in a partnership, and men are just as easily affected by these adverse outcomes as women. Okay, they don't go through quite the same physical experiences, they don't have quite the same endocrine changes, but nevertheless, they're very much invested. So what Tom found was that a significant number of male partners of women who miscarried also experienced very similar symptoms, post-traumatic stress disorder symptoms. Not as many as we found in the women, not as many of the men were affected in the women, but still a significant number of them were. So I think it's important to recognize that miscarriage affects not just the woman who has the miscarriage, but her partner, and then potentially, of course, her wider family and the children as well. We haven't studied the children as well yet, but I wouldn't be at all surprised if that doesn't also apply.
And I assume the same thing for same-sex couples as well. It's just that it has a slightly different bearing as to whether you're carrying the baby or not, but that's fascinating.
Yes, I mean, Tom's study hasn't yet looked at same-sex couples. The number of those that we would be able to access to be able to get sensible numbers of data would be more tricky, but it's a good starting point to go from.
Yes, exactly. Okay, I've got some great questions here. First off to Arri, is baby aspirin or blood thinners being introduced as part of regular miscarriage prevention like progesterone is?
So this is really important question. We know that baby aspirin and other blood thinning drug heparin are important in women who have got a sticky blood disorder. So we call it antiphospholipid syndrome. It can be lupus anticoagulant or anticardiolipin antibodies. That means that the woman has a sticky blood disorder, then correcting it with blood thinning drugs like baby aspirin and heparin makes sense. But what's really important is that if there isn't a sticky blood disorder, then there is nothing to correct. And we in fact know that if there is no sticky blood disorder, taking aspirin could be harmful because there is no problem with the blood and you are thinning it with blood thinning drugs, and that could actually make things worse. So it's really important that one gets tested for sticky blood disorder if they had repeated miscarriages, and only if there is a problem, then they get blood thinning drugs like aspirin and heparin. Otherwise, it's important not to take aspirin.
Thank you. Siobhan, is there a thing as too much progesterone, and how is it best to take?
So you can always have too much of any medication. So an overdose of a medication will also do harm. So it's important not to take too much. So the randomized controlled trials that are led by Arri actually show that 400 milligrams twice a day of vaginal progesterone from 4 to 16 weeks was enough. It is very tempting to take more, but that is the maximum dose. It was enough to prevent miscarriage, and taking more than that could do harm.
Phil, this is a really interesting question. Of the miscarriages caused by the lining not detecting abnormal embryos,
Yes.
is the research geared towards preventing those from implanting? So
yes,
essentially,
yes.
Yes, okay.
Yes. So the idea would be at the moment that we have a group of patients who present to either to the early pregnancy unit or to recurrent miscarriage clinics, and they have no difficulty in getting pregnant. In fact, they get pregnant rather too easily, but they keep miscarrying. So you can imagine how awfully depressing that is, that you get pregnant very easily, you keep miscarrying, you keep miscarrying, you keep miscarrying. And the reason for that is because the body isn't identifying embryos that you shouldn't really implant. It's a little bit like what happens in an IVF unit when the embryologist looks down a microscope and picks the really good embryos to maximize the chance of success. Here, the body itself is picking the good embryos and rejecting the bad embryos. So yes, the idea would be that if we could fully understand that and provide a treatment for it, and Siobhan and Jan are some way along understanding that and providing a treatment, then what would happen is that those people wouldn't get pregnant so easily, but when they did get pregnant, it would be a keeper as opposed to a miscarriage.
Okay, great. So sort of reducing the trauma of miscarriage by,
Certainly would, I think, yes.
Okay. Arri, due to the results of the PRISM trial, many women are trying to access progesterone if bleeding in a subsequent pregnancy, but unfortunately finding that many doctors are not prescribing it. I do relate to that myself. Will this be part of national guidance? And is there any advice that you have for women who are currently in this situation?
So this is very much a subject of discussion at the moment. We surveyed nearly 200 healthcare providers up and down the country, and we were pleased to find about 74% of clinicians are happy to provide progesterone to women who need it, but 26% aren't. And when we ask them, why is it that you are not providing progesterone for these women, their answer is that they are waiting for national guidance, before they would be comfortable to do this. And so NICE, that is the body that looks at recommendations and issues guidance for practitioners in the UK. They are looking at this very question right at the moment. And I think a recommendation from them is imminent. Maybe it could be within a matter of a month or two. And I think hopefully if they, one hopes that they will make the right recommendation, and after that, it should be easier for women to access the treatment that they may need. But at the moment, I do appreciate that there are women who may not be able to get the treatment. And we did, in fact, in a survey that was only completed a few days ago, ask the question, if you are needing progesterone and your doctor isn't giving that to you, what would you do? And we surveyed over 1,000 women in the UK, up and down UK. And what we found was that about 40% said that they will go to another NHS clinic. And another 40% said they will go to a private clinic to get the progesterone. And worryingly, about 10% said that they will turn to the internet to source progesterone from the informal market. And I think that is not the right thing to do, because you don't know what's in that drug and so on. So I think it's really important that we have guidance on this, and there is a kind of standardization of practice up and down the country. But I do think that is imminent.
It just is a sign, isn't it, of how desperate people can be that you return to the internet. So thank you for that. I've got another question here about miscarriage, and the reason I raised it is because I've had two myself, so I understand where this is coming from. What's the most successful way of treating miscarriage? And I'm not sure who is best placed to answer that, so I'll leave you to fight it out amongst yourselves.
It's not me, that's for sure.
Siobhan,
So
Arri.
Arri, you go. That's right.
Yeah, sure. So I think in terms of treating, if the wish for the patient who's sadly suffered the miscarriage is to have it resolved soon, as quickly as possible, then without a doubt, surgery is the way forward. And the surgery, we've shown that if we were to use a medicine to prepare the neck of the womb first and then have the surgery, then it is even more effective and safer. Surgery can be done without anesthesia, so it doesn't necessarily mean having to go to an operating theatre, for example. So I think if the wish for the couple, for the woman, is to have it resolved quickly, then surgery. But for some people, the idea of surgery is something that they would want to avoid, in which case managing the miscarriage with medicines. So there are two medicines, one's called mifepristone and the other one is called misoprostol. And again, the work that was funded by the Tommy's charity in collaboration with the government funding body NIHR has shown that using the combination of the two medicines is more effective than using one, which is the current practice at the moment. So medical treatment with tablets is the second option. The third option, which is expectant management, which simply means just giving the miscarriage time for it to resolve, it doesn't appear to be very effective. And that is an option for anyone who wishes to not have any medical intervention. But with miscarriage, it's not a great option. If it's an incomplete miscarriage where the body has started to expel some of the pregnancy tissues already, then giving it time could be a good way of managing that miscarriage. But with miscarriage, we are now suggesting that the operation or the tablets are the right way to go forward.
I wonder if they're asking if there's a way of treating it so that we don't suffer from a miscarriage in the future, or is it actually just in the soup with other miscarriages, or is there a specific way that we can tackle it to get
So I think that one of the important things is, if you have a miscarriages, is to see if your miscarriage tissue can be tested genetically. Because one of the studies we found during our literature review for this Lancet paper said that if you have these miscarriages, you're actually increased risk of having a chromosomally abnormal pregnancy. And that's critically important, because if you've had a chromosomally abnormal pregnancy, there's no need to feel guilty or that you've done something, or you didn't have progesterone, or you did have progesterone. So at the moment, the NHS guidelines is if it's your third or subsequent miscarriage, then you can have it tested. And I think when you go into hospital, it's important to ask that. Unfortunately, at the moment, the funding doesn't exist to have the first or second one tested, but certainly the third and subsequent ones. And that is really important that you get that and make sure that the doctors are aware that you want it tested and that they do that, because it makes a massive difference to how you cope with the miscarriage, what preventative treatment you would need in the future there.
That's incredibly helpful advice. Thank you. Phil, yes.
To add to that, so I mean, the work of the National Center for Miscarriage Research is about preventing any miscarriages that may occur in the first, say, 14 weeks. of pregnancy. So that would include missed miscarriage. So all the discussions relate to missed miscarriage, roughly in the first 14 weeks of pregnancy. And the Tommy Center in Manchester would be focusing on miscarriages later on in the pregnancy, so mid-trimester losses. So yeah, Tommy's, we have it covered in terms of early losses with the National Center for Miscarriage Research, and later miscarriages with other centers elsewhere in the country.
Okay, thank you. Phil, your research suggests a link between bacteria and pregnancy complications, as we've heard. This questioner says, I had a very healthy, normal full-term pregnancy, but had a late miscarriage second time around due to my waters breaking early. Could this be a bacteria thing rather than a weak cervix?
Well, the answer is yes, it could. In fact, we've done quite a lot of work linking the bacteria in the genital tract specifically with the risk of preterm premature rupture of membranes, which is what your questioner has experienced. And she's absolutely right that probably the two common reasons for that are an adverse reaction between the mother and the bacteria, or some sort of cervical weakness. The fact that you've got to term in the first pregnancy maybe points away from the cervical weakness, although there's growing evidence that if you have a difficult vaginal delivery, or particularly if you have a cesarean section right at the end of labor, that might do some damage to your cervix and might cause later problems in the next pregnancy. But other than that, yes, it is possible that the cause of that was an adverse collection of microbes and the response of the mother to it.
Okay, thank you. Thank you for that question, and I'm so sorry for your loss. Siobhan, do you see anything pointing to a higher rate of miscarriage associated with IVF, IUI, or assisted reproduction pregnancies?
No, I think the miscarriage rate's very similar. It's just that it's actually every miscarriage, is important. Every miscarriage matters. But if you've been through IVF or IUI and then you miscarry, it is particularly difficult to take, and it's particularly disappointing. A lot because you're aware you're pregnant and you're initially happy that your IUI or IVF has worked and you think you've made it, and then to miscarry, it's particularly difficult. So in my experience, people who miscarry after these fertility treatments really struggle. And they're a group of people who particularly need support, and we particularly need to identify those who are suffering from post-traumatic stress syndrome to make sure they get adequate support. So it is a really difficult thing to take, and it is important that you get support from your family and friends, or from your general practitioner, or from self-help groups. It's not something to take lightly there.
And following on from that, Siobhan, for someone who's had recurrent miscarriages, what's the chance of a successful future pregnancy? I mean, I guess that's so many people want to know the answer to that, if there is one.
Well, the chances are still very, very good. And I think that's the important take-home message. So for example, I do know the data from my clinic. So I have a recurrent miscarriage clinic where you have to have 2 or more previous miscarriages. And I know that 60% of people do take home a baby. So it's actually very, very high. But I also know that some people don't. And I think it's also important to be realistic. So to have realistic expectations. So if you've had more previous miscarriages, or you're in an older age group, you are more likely to miscarry again. If you've had less previous miscarriages in a younger age group, you're less likely to. So I always say to people, it's important to have realistic expectations, and then the support of a miscarriage clinic. And then you've got a very good chance of future pregnancy. Sadly, one of the reasons people don't get pregnant again is actually they never conceive again. And I think that despite all the efforts and all the support that we give in my clinic, a lot of people are too scared to try again. And this is a really important message. Do not be too scared to try again. Make sure you've got realistic expectations of your next pregnancy. Make sure you've got adequate support in the next pregnancy. And that's what you need to get you through this difficult early pregnancy period.
Oh, such compassionate advice. I just want you all to look after me forever. But can I ask you about age? Because we are constantly told that, we're basically on the rubbish heap once we hit 40. But I wonder how up to date those research figures are, and how much work you did in terms of age and the impact it has on miscarriage.
Yes. So basically, we did an analysis of a very large number of papers out there. So you're talking about using data from several million pregnancies. And there is a very, very strong association between age and miscarriage, particularly if you're age over 40. So if you're age over 40, you do have a 45% risk of miscarrying in your next pregnancy. But that doesn't mean that you can't ever have a baby. It means that you need to be realistic about your expectations, because it is so awful miscarrying. It's so awful emotionally, and it's so difficult to cope with. So in the over 40s, the message is be realistic, accept that you may miscarry or you may have a baby, and make sure you have support in place to get you through whichever one of those happens. The reason that's so important is that the reason you miscarry in that age group is most likely to be because the pregnancy wasn't normal. And so that if you try again with a normal pregnancy, you will have a baby. But if you get very distressed of severe PTSD after miscarriage, then you can never face trying again. So the message with the 40s is be realistic, keep going, and have very good support networks in place.
Okay, thank you, Siobhan. Arri, do we have any idea at this point why Black women are so much more likely to miscarry? And what are we going to do about this?
So we have some theories, but we don't have data or research evidence to tell us what may be going on here. So the first question that we would want to ask is that, is there something different in the biology in terms of the way a Black woman's body handles a pregnancy? Is there a reason to suspect that the lining of the womb is not behaving as it should do? Could that be related to the microbiome? So there are really important research questions that the Tommy Center needs to ask about the biology of how women carry pregnancy, particularly Black women carry pregnancy. And then there is the question, is it related to social factors? We know that social factors have an impact on all sorts of outcomes, particularly in pregnancy. And so we need to ask, are there explanations in the kind of social factors to explain the increase? We know that Black women are more likely to have certain conditions. For example, they are more likely to have fibroids, and fibroids can affect the way a pregnancy implants in the lining of the womb. And could that at least partly explain what's going on here? So all of these research questions are high priority questions for us, and within the Tommy Centers, we are hoping to look at that carefully over the coming years. But at the moment, we don't know for sure why this is the case. In terms of what we do in the meantime, I think it's really important to appreciate that the risk is higher in Black women, and provide appropriate care as we would provide to women who are at high risk of having miscarriages. So I think, having access to specialist care, pre-pregnancy clinics, for example, having better care during pregnancy and childbirth, because Black women are also at increased risk of other pregnancy complications like preterm birth and preeclampsia and so on. So I think enhanced care during preconception, during pregnancy, and during childbirth, we should be providing that at this stage while we are trying to develop greater understanding of what's going on.
Thank you. Can I ask you about, and I hate the phrase, but natural killer cells? I mean, I always think that sounds like a Tarantino movie. And I know that it's quite new science and it's quite controversial, but did you look into that? What's your take on NKCs? Phil, is that you?
Who's going to answer that? Let me say that so I think that natural killer cells get a bad name exactly for that, for the Tarantino-esque name, We know, and a lot of this has come again from the important work that's being done in Warwick, Jan Brosens, that natural killer cells in the uterus are very important for the remodeling that occurs with each menstrual cycle. So every month, of course, a woman sheds the lining of the womb, the lining then regrows. Some of the cells that are left behind are sort of dead and dying cells that need to be cleared away to make space for the good cells, you know, a bit like weeding the lawn, I guess. So you need those natural killer cells. They need to function correctly within the uterus. I think a problem we have in the world of miscarriage is that people are measuring natural killer cells in the bloodstream, which don't really have that much to do with what's going on with the natural killer cells in the uterus. So I think that there is personally an element of hocus pocus in all of that. I think we need to recognize that natural killer cells are important, normal things that you're supposed to have in your womb and are good for you.
That's good to hear. Siobhan, did you want to add anything?
Yeah, oh, absolutely. Yeah, I absolutely agree. The lining of the womb is a very delicate balance between a tissue that can support a pregnancy, a tissue that can protect against infection, and a tissue that will not support a pregnancy if it's abnormal, so can choose normal from abnormal and break down in that case. So in order to have this clever balance, so it's the right number of natural killer cells compared to other cells that matter. And the natural killer cell test is a way of assessing the balance of the lining of your womb. But they, as Professor Bennett has just said, natural killer cells have lots of good functions. And then it's always important to realize that.
Okay, great.
I emphasize strongly that what Siobhan is talking about there is testing the natural killer cells inside the womb, which is the research that they do at Warwick, as opposed to what we see a lot in the private sector at the moment, is people measuring natural killer cell levels in the circulation, which don't really, the two are not the same things.
Okay, that's super helpful. Fascinating. Phil, we've had a question about finding the reasons for miscarriage. From this questioner, doctors said my son's heart did not form correctly and said there are no genetic or chromosomal issues. So it seems to me like there was no reason. Is there anything more I can do to try and find out the reason?
Let me begin by saying more generally, when I said there's always a reason for a miscarriage, it doesn't mean that we necessarily know what that reason is. And in fact, one of the important goals that we have as part of the Tommy's Miscarriage Research Centre is ultimately to be able to explain to as many women as possible why it was that their miscarriage occurred. And at the present time, in many cases, we don't know the answer to that. So in this particular case, we're talking about a heart problem in the baby, presumably that led to a miscarriage or a stillbirth or to the baby dying in the womb. So that would be an explanation for why the pregnancy went wrong. But I agree that you then need to answer the question, well, why did the baby end up with that heart problem in the first place? I'm not an expert on heart problems in babies, but I think about half of those are associated with some sort of chromosomal or genetic abnormality, but the other half are not. You know, there are many people in the general population who've got congenital heart disease that's not linked to a known genetic problem. But I guess that's research that's needed to be done on heart disease in pregnancy, you know, on heart disease in babies more generally.
Yeah, thank you, Phil. And yeah, again, I'm so sorry for what that questioner has been through. I've got time for one final question from the floor, the virtual floor, and then I'll start wrapping it up. But the final question actually goes to the heart of everything we've been talking about. So Arri and Siobhan have mentioned already the amazing care that the Tommy Centre are offering to women to take part in their clinics and research trials. When do we think that this kind of care can be offered to all women in the UK? Arri, can I come to you first on that?
Sure. We are really keen that expert care, the appropriate care, is given to every woman after every miscarriage throughout the UK, not just in Birmingham, Coventry, or London. And to this end, Tommy's have been working with the National Centre to develop a package of care that we hope that we can take to every clinic up and down the country. So this is very much a program of work that we hope to follow through in the coming 2 or 3 years, and we would work with healthcare providers up and down the country. We would work with policymakers. We would work with any stakeholder who is trying to make a difference to provide very high quality care throughout the UK, not just in 1 or 2 specialist centres. And I think what we think is important here is to to appreciate that there are women who would need emergency care when they are having miscarriage, and emergency care is best organized in early pregnancy units, EPUs, as opposed to being delivered, say, in A&Es. In some parts of the country, women will need to go to an A&E when they're having a miscarriage, and they really don't get the right care there. They don't get the ultrasound scanning, they don't get the expert care that they should be getting at that stage. So I think we need to improve the coverage of emergency care through early pregnancy units. And then as far as the couples who've suffered the heartache of repeated miscarriages are concerned, we need to structure the care so that women who've had 1, 2, 3, it doesn't matter how many miscarriages, they all get the appropriate care. And for that, we are suggesting, as Siobhan mentioned earlier, the graded care model, which would assess after every miscarriage, what are the risks here and how can we best address it? And we are working with policymakers to kind of work out what would be the right way to offer the graded model of care. So I think we are very focused that the care is not provided from a few specialist centers, but care is provided, uniformly high quality care is provided throughout the country.
Thank you so much for that, and for all of this. I found it incredibly helpful and illuminating, and I wish we had more time, as I can see that there are still so many areas to discuss, but fear not, because Tommy's will be running a series of follow-up events exploring some of the issues that we've covered here today. So please do reach out to your contact if you're interested in joining in. I personally have found this discussion incredibly moving and very, very practical and compassionate all at once. I think that one of the things that I struggle with going through miscarriage is a feeling of being alone, or a feeling that people don't care. And you have put me right on that. And I really feel that you genuinely care and are doing everything that you can. And I just want to thank you on a personal level for that and for your incredible work. But the work isn't finished. This is only the start. So now we need to make sure the government listens and the NHS adopts Tommy's recommendations, because only then will we be able to truly transform miscarriage care for families across the country. And to do more, Tommy's needs your support. In just 5 years of Tommy's research, they've shown that miscarriage does have underlying causes, that there are tests and treatments which can give families hope, and that we can improve care. Supporters like you have done this by funding Tommy's national.
I didn't get that.
Sorry.
Could you try again?
Did you hear? My Siri. My Siri's transcribing this entire speech. Supporters like you have done this by funding Tommy's National Centre for Miscarriage Research and joining the dots between basic science and clinical care. So thank you. Did you know that Tommy's is one of the top 5 funders for pregnancy research? But for every £1 the NHS spends on pregnancy-related care, just 1p is spent on research. Compare that to cancer, which is 12p, or heart disease, which is 7p. And I think you'll all agree that this needs to change. With more investment in research, we can find the answers to prevent the devastation of pregnancy and baby loss. The incredible professors we've met today have shown us that. So finally, I'd like to thank you all for giving your time to support Tommy's mission, for opening up and asking some fantastic questions, and for helping to make the UK the safest place in the world to give birth. Together, we can give parents the best possible chance of a happy, healthy pregnancy, and ultimately save babies' lives. Thank you so much for coming. Thank you to these incredible panelists, and thank you most of all to Tommy's. Have a great day.
Thank you.